phenomena of physician-AI interaction.
Thanks so much. Thanks so much to everyone for being here and for the conference organizers. And also, briefly, also want to congratulate all the prior speakers on their really incredible technical work. I'm a minimally invasive surgery fellow at Michigan Medicine in the Department of Surgery. And I appreciate the time to be able to share my work. I've been fascinated for several years now and been studying how physicians can leverage AI to make better patient care decisions at the point of care. And so that's what I'll be talking about. But before I kind of delve into that topic, I actually wanted to start by telling you a story of one of my favorite stories of computer-aided decision-making. And this story actually comes from 1997, after Garry Kasparov, the chess grandmaster, lost to IBM's Deep Blue. After he lost that match, he became fascinated by how humans and computers can think together. And so he actually started teaching chess in new ways with the help of chess-playing computer algorithms. And in his studies, he noticed a very peculiar phenomenon emerge, which is that specifically he noticed a small group of weaker-rated chess players that were consistently beating stronger chess players. And specifically, he noticed that this small group of less skilled human chess players collaborating with the computer algorithm tended to win games against highly skilled human chess players that were collaborating with the exact same computer algorithm. And when he looked into this phenomenon, he noticed that the difference between these two groups was that the less skilled players had specific collaborative processes for how to interact with the computer's recommendations. And so, but in contrast, the more skilled players didn't have any process for interacting with the computer's recommendation. And one of his, as he described in one of his talks, and from the 2010s, he said that he noticed that there was a lot of friction between the skilled player's strong sense of intuition as to what the right next best step was versus the computer's recommendation. And that friction sort of altered their combined gameplay in what he described as very unpredictable and sometimes often harmful ways. And so that gave rise to what's now called Kasparov's law, which is the idea that a weaker human plus a computer algorithm collaborating via a strong, well-defined process will tend to outperform a stronger human collaborating with that same computer algorithm but without an interaction process. And so as you can imagine, that observation or that theory is very relevant to how decision-making algorithms should be used in clinical practice for making decisions about patient care. Now, the sort of guiding principle or the dogma for all of clinical AI up until now has been that these algorithms should augment humans or that an AI-equipped human is the superior decision-making paradigm compared to what either decision-making tool, human or algorithm, can do alone. But now that more and more algorithms are starting to be tested on real clinical scenarios, that narrative is starting to unravel a little bit. It actually turns out in studies over the past few years that delivering the best prediction to the human physician does not automatically translate into the best possible patient care decision. Now, to be fair, there is some evidence that physician-AI collaboration is very effective. This is a landmark Swedish mammography study from a couple of years ago showing that when AI and radiologists collaborate on diagnosing breast cancer from mammography, the AI-assisted approach leads to higher, more accurate identification of breast cancers compared to human radiologists alone, and also cuts the radiologist's workload almost in half. So there is some evidence that collaboration is still highly beneficial, but within the last year or so, there have been numerous examples emerging from the literature where algorithms have been studied in real-world clinical practice where that collaboration actually doesn't help. And so the highest profile example is a study from around this time last year. It's a study of large language models versus physician specialists in diagnosing complex cases. Now, when the AI worked independently to diagnose these complex cases, diagnose these very complicated patients, it achieved a 92% accuracy. Whereas physicians collaborating with the AI assistants only achieved 76% accuracy. However, when the physician was working alone, their accuracy was 74%. So collaborating with the algorithm only increased their accuracy marginally by 2%, while the AI, unaided by the human, achieved remarkably higher diagnostic performance. This phenomenon has actually, this is not an isolated study, this phenomenon has borne out in several other studies of chest x-ray reading, EKG reading, lots of other clinical scenarios, but I think this is probably the most highest profile of them. And the theme across all of these studies is that, again, giving AI, clinical decision support AI to human physicians does not change their performance, or sometimes maybe marginally improves it, but that AI unaided by the human tends to surpass what either can do alone. Now, I'm a surgeon, and so there are several examples of this from the world of surgery as well. This is one study that shows this same exact phenomenon where when you ask AI versus surgeons to predict what will happen to patients postoperatively as far as complications go, in most domains, the AI outperforms the human surgeon in predicting what will ultimately happen to the patient. But then when you give that prediction to the surgeon's performance in predicting complications doesn't actually change at all. And this is actually borne out in some of my own research as well, which not only shows that surgeon-AI collaboration does not outperform what the algorithm can do alone as far as predicting postoperative complications, but more specifically, that surgeons tend to disagree with the algorithm at increasing rates as patients get more sick and more complicated, which are exactly the very scenarios where they might actually stand to benefit from those algorithmic recommendations. And so there's a very common explanation for this phenomenon as it's emerged over the past few years, which is that, physicians aren't completely comfortable with using AI. They still doubt its utility. They fully don't understand how these algorithms work or what its weaknesses are, which I think is all true. But what I want to propose is that there's an added layer of complexity here, which is that even if we physicians did trust these algorithms, we don't yet fully understand how to incorporate their recommendations into our intuition or into our clinical judgment. And fundamentally, I think this is because these are probabilistic tools, but we as humans are not probabilistic thinkers. If you've ever been on rounds with physicians or in medical school lectures, we don't think in terms of probabilities. We think of terms of mechanisms and pathophysiology and clinical narratives. And so because of this limitation in our ability to engage in Bayesian thinking, it sets us up for a weakness as far as incorporating information from algorithms to update our thinking. And so this is one of many excellent examples from high-profile literature showing from the past several years that physicians generally exhibit, suboptimal performance at updating our reasoning with statistical information about new tests or outcomes. And so this highlights this phenomenon of predictive dissonance, which is, the term that I mentioned in the title of this talk, which I think is one of the biggest rate-limiting steps in this field of using AI for clinical decision-making, which is that when a human predicts one thing or believes one thing, but the algorithm predicts another, we're at a loss for how to fully, accurately, and consistently incorporate that dissonant prediction into our clinical judgment. So what are some options for better collaboration? One proposed strategy is something you may have, I'm sure many people in this room are familiar with, which is explainability. And the logic here is that, these models are very complex, they're black boxes, and so explaining how the algorithm arrived at its prediction might be able to help us better weave its recommendation into our decision making. But unfortunately, what studies around explainability show thus far is that explainability in the way that it's currently done generally does not tend to improve decision making. This is an excellent example of heat maps that are overlaid on chest x-rays that attempt to explain how an algorithm arrives at a diagnosis from a chest X-ray to a radiologist, but it turns out that when the algorithm makes an incorrect prediction, giving the heat map to the radiologist does not mitigate the negative effects of that incorrect prediction. And so ultimately, I think there are two main flaws with how explainability is done thus far. One is that they're often statistical measures themselves that clinicians aren't trained to interpret or respond to. And the second is that in many cases, they're not actually, accurate representations of how the algorithm arrived at its prediction. One alternative solution is to go back to the Kasparov's law idea that he first uncovered in 1997, which is to use structured interaction protocols between decision-making algorithms and physicians to ultimately make patient care decisions. And so this is an excellent example from radiology, again, showing that when you give a weaker radiologist, or a less experienced radiologist, I should say, access to an algorithm, and you give more experienced radiologists access to that same algorithm, the weaker radiologists actually tend to outperform the more experienced radiologists depending on what collaboration protocol is used. But I think the boldest and most promising solution as it relates to physician AI collaboration is to actually stop trying to force human intuition to merge with AI predictions, and instead to let AI operate independently on tasks that it's better at, so that physicians can focus our expertise on other areas. And so one radical version of this is what's called role separation. And so this would take the form of having AI handle certain routine cases independently, like normal chest X-rays or low-risk mammograms, while doctors can focus on the more complex disorders or rare conditions with atypical features. This is an example of an excellent study, again, from radiology, showing that an AI system could very reliably label the vast majority of chest X-rays, of normal chest X-rays given to it, which then freed up radiologists to devote much more time to studying the images that were deemed more suspicious or higher risk. However, this is in contrast to when AI and radiologists were forced to read the same X-rays together, in which case it took twice as long with no improvement in performance. So there's a lot of work that's been done on human AI collaboration, as you've noticed from a lot of the literature I've cited in radiology, but the work that I'm focusing on is around what optimal collaboration for patient care looks like in surgery, both in the operating room and outside the operating room for care of surgical patients. And so I think the bottom line ultimately here is that the capability of these tools for clinical decision-making is very, very rapidly evolving. And that's not really the rate-limiting step. What ultimately the rate-limiting step is that no matter how accurate or how powerful these models get in giving us the right clinical answers, the fundamental interaction challenges still remain. And I think one of those biggest challenges is how we can figure out how to incorporate these recommendations into our clinical judgment. So thank you.
Thank you so much, Jayson, for that talk. We have quite a few questions, so we'll see if we can deal them. Again, if you want to ask a question in person, you do so